from African Wave African healers for preserving life. With skill in their hands, they can do walked we collect experience, fruitful collaborate the exploration abilities, spreading health awareness. Is taking root. Continent. Third steps. And Shani medical healer rise anew. The timeless truth. Health knows no borders. Border endeavor of the healing commonwealth. Clothed in white. Together, we shine. Friendship between China and blue water of the world. The light. The land. Waves of Chinese and Africans have been raising against time life. With skill in their hand, they can do walking medical expertise, bringing fruitful to the pioneering, spreading health awareness to cons is taking root. Shared steps and shared struggles. The journey of growth. The numerous truth. Borders. Border endeavor of the healing commonwealth. Moved in white. Together, we shine. Friendship between China. Every corner of the world. We're live. The light. From China's fertile land to African savannah, Chinese healer raising against time and their heart kindle faith. We're having hand eyes medical expertise, bringing fruitful across the land. From the fountain to the pioneering exploration surgeries. awareness. To co-train route. Breadth across the continent. And share the journey of grows ever richer. Healer, rise new truth. A healing commonwealth. Clothed in white. You shine between China of the world. Now, the light hits fertile atlas of Chinese can healers against in their hands and their light. We synergize medical expertise, bringing fruitful collaboration from the found to the pioneering expert surgeries. Yes. To Churchill is taking root. Ordinance. And share of grows ever richer. Healer rise anew. Health of the healing commonwealth. Clothed in white. We shine between China every corner of the world. How it boundless of waves of Chinese in Africa have been raising against with skill in their hands. They kindle faith bringing fruitful collaborate to the pioneering declaration health awareness is taking root. Ordinance steps and shared the journey of medical care. What the new truth. Health endeavor. Healing commonwealth. clothed in white. Together, we shine between China, blue water of the world. The light land to the bound waves of Chinese have been raising against time with skill in their hands. Light up. Waki's medical expertise and fruitful collaborate. Foundation exploring minimally invasive surgeries. Spreading health awareness. Jukons is taking root. The continent. Shared steps and shared the journey. Medical. Each white-coated healer rise anew. The timeless truth. Health knows no borders. Order endeavor. Of the healing commonwealth. Clothed in white. Together, we shine between China and Africa, the world, where life, the light, had set sail. Fertile land. Boundless waves of Chinese in have been raising against life with skill in their hands. They kindle faint light. Waki's medical expertise bringing fruitful collaborate. From the fountain to the pioneering of minimum health awareness to future talents. China is taking root. Broaden it. It steps and share medical care. It's a new truth. Health borders. Endeavor of the healing commonwealth. Clothed in white. Together, we shine and every corner of the world. Where life, the light, had From China's fertile lands, Chinese and have been raising against with skill in their hand. They kindle fame in hand, eyes medical expertise, bringing fruitful land. From the to the pioneering exit surgeries, health awareness, future tell.
Which colleagues from Africa can join us online. Join us and fast to leave fast section of the CAUA Express on air. Shanghai General Hospital. And it's which you serve as your host. The event is organized by the Alliance and the Chinese African Association Ecological General Hospital Shanghai as a we extend to organize for we are deeply honored to Professor Han Bangmin, Chef Maury from the exhibition. This distinguished panel will moderators include the hospital university, Professor from Dr. Brick, Dr. Mohammed, Dr. Alice Nia, Professor Cui Di from Shanghai General Hospital, Mohammed Omar from Cream, Professor Yifei, Professor Hamoud from Tongji Hospital, Tongji Medical, Professor from Morocco, and Dr. by Professor Hai General Hospital. It's a profound honor for me to be part of this all of you. So 2025 dedicated to the long-term between China and Africa. Represents a significant practice our clinic in today's activity. So first, please welcome Professor Xia and Professor Xia, the prostate. So
dear Dr. Professor Han, dear colleagues from China, I'm great honor you on air. Also last year, 3 we share technologies. A great system and establish Africa. In urology department and we hold first. We run online training. This membership, the system is brilliant to communicate and help us to build synergy. They also allow from each other. We apply local companies modern friendship between China and we share and press better message.
Share for your wonderful remarks. Now, next work is Jess.
Professor Chia and dear colleagues for it. My great pleasure to join your platform with air. On behalf of my warmest welcome to all between urological body across Africa. We are the advanced minimally platform serve as to share experience and treatment care technology has been minimally robot and whole laser technology spectrum of patients during the malignancy. Today, we will share our experience in the surgery and practice by working elevator throughout the effort together. This China, Africa, Europe research. I wish this advance between our grew. Thank you.
Thank you, Professor Han, for your and work is Jess.
Cairo, and good afternoon. Welcome all the professors and very important to force surgery. I want to thank the Chinese team and the Chinese Association, Surgeon Association, and the Egyptian Association. And I want to, and of course, and special high general cases and giving show this in the It is very now our young machine and sodium and with this and how and for the prostate it's a hot topic now is also in the very near future thing. So laparoscopy or everything will be. So this teach our colleagues information and more knowledge about this. So to be with you today, I visited and I saw how many lasers and robotics very efficiently all this already done. We'll get benefit. I hope success.
Thank you, Professor. We can in Africa Association our stage about in upcoming demonstration and the discussion session. China and Africa, who will get us welcome our first turn, Professor Sheriff Ukraine, Hamed, Dr. Elias,
for the introduction from professors and my name is Department, the first affiliate hospital of Anhui Medical University to join the surgery. So it's my great pleasure and the team from. So I think I will be co-Sheriff Murad and Professor Ahmed Mohammed and Professor. We would like to famous surgeon. And today his status the surgery is the metabolic robot assisted radical prostatectomy. Actually, this is a very new of the from the Shanghai General very well, and he quite a lot of prostate cancer patients already. Yes. Okay, so this is a little bit low. Could you off your microphone?
Can you hear me now?
Now we can about your case, right? I had in my hand as well with positive for with 7 with 2 and 2 and this patient Liu.
Yes.
Please give us a little bit hint. As far as I know that use the robotic surgeries. The platform you
Experience is my here on this Chinese system. So your with definitely is challenges. It's quite old now to keep the and according to around 3 and neck and
yes, we can have.
Oh.
Just feel free to talk.
I don't know. Here it is. Triangle keeps the actively. From the robotic system made in China.
Okay.
Your
I picture I see
advantage.
that the vision's colors looks
This is similar. It's better. Differentialism. I think this is the
okay. Sure. Do you have the Chinese platform in of the? Do you have any of the
robot?
Yes, because now previously we only have one brand. In China we have quite a domestic brand like, and I see from any of the international conference heard them.
I already have bought for machine. It will be installed August.
Wow, very nice. Very nice.
And I more 3.
Very great. So in of the medical to this Chinese at the remote internet possible. This year, I think last year, Zhang Xu from CUA have been demonstrate the robotic state 5,000.
擦镜子。
So in China, the attorneys already have measure our public would be support about robotic surgery. The over than 100 kilo insurance in China. In the future.
So I know that one case of to Kuwait.
Yes. Now tell you is a very good
I think it's this is the future. It's coming.
yeah.
But the machine, I think that the MedBot machine is a very good one, and it mimics the Da Vinci. So I think that it will be very easy and friendly use.
Okay, so our other moderates online, Professor Ahmed Benkrein or Professor Knop or Professor Ilyas Niaga. Are you online now or not yet?
Yes, Professor online.
Okay, so I cannot see you on the screen. Could you please open your camera,
Video.
please, so we can find you on our screen? Okay, now I can see name Dr. Niaga, right? Ilyas? Am I pronunciation right? Okay, nice to see you. Okay, we cannot still hear you. Can you open your microphone, please?
Yes, I think I can hear you very well.
Ah, okay. Okay. Welcome you. Okay.
Yeah, welcome. Good morning.
Okay, so now Professor Liu Chen is operating with male patients with prostate cancer. Now he used the the transperitoneal. Is it a transperitoneal approach, Professor Liu, or a ritual peritoneal?
Classic approach, transperitoneal.
Transperitoneal. Okay. So what's your hobby, Professor Knoll? So you do you prefer the transperitoneal or the ritual peritoneal approach to do the robotic radical prostatectomy in your center?
Muhammad Qutb.
Yes, in our center, actually, we prefer the transperitoneal. Most
Mhm.
of the cases are performed using the transperitoneal. Rarely we use the extraperitoneal or the retroperitoneal approach. But the difference in the transperitoneal, sometimes you go posterior to the bladder first, or
Mhm.
sometimes you go anterior to the bladder first to start at the bladder neck. This is the only difference. But both techniques that we are usually using are the transperitoneal approaches. But either to start with the posterior to the bladder, dissecting the vase and the seminal vesicle first, then go anterior. Or most of cases, we actually go at the bladder neck, cut the bladder neck, and go, although it's transperitoneal, but we go from transperitoneal directly from anterior to the bladder neck to the vase and the seminal vesicle at the very beginning.
Ah, okay, thank you. I think it's very similar in our center. Most of the surgeons prefer to do the transperitoneal approach, but nowadays we have another platform with a single port robot. So now we use the single port platform to do the ritual peritoneal, and for the other with the Da Vinci or the other platform, we use the transperitoneal approach. Okay, thank you,
You're
Professor.
welcome.
And for Professor Niaga Ilyas, can you hear me?
Yes, good morning. I can hear you very well.
Good morning. I'm from China. Okay, nice to see you online. So
Yes.
what is your hobby in your center, and what is your preferred approach for the robotic or laparoscopic prostatectomy, a transperitoneal or a ritual peritoneal?
No, at the moment we are not doing robotic surgeries. Where I'm coming from in Kenya, in my center, we don't have a robot. We don't have a robot in the country actually. But I trained in the robot some years back. And I know you'd use all the approaches, transperitoneal, retroperitoneal. We would go radius sparing. Use radius sparing approach. But for now, for radical prostatectomies, we are still doing the open approach.
Okay. So actually, how do you feel about anastomosis when you use a laparoscopic stage? Sometimes, especially in the patients is quite fat with very high BMI, sometimes very hard to do the stitch, right?
Yes, it's hard, especially the anastomosis
Hemlock
because of
来
the depth of the pelvis.
Okay, thank you very much. So let's back to connect to Professor Liu. So I see now you're trying to dissect the seminal vessel, right, Professor Liu Chen?
Hello. Pardon, please.
Okay, now you're trying to dissect the seminal vessel, right?
Yes.
So are you going to open the dentabellus fascia, or you will spare it for this
I
patient?
will open it very soon.
Okay.
But before I open the dentabellus fascia, I will completely to establish the plan. Hemlock.
So looks this case is a very nice case, right?
What?
It looks very nice. It's nearly no bleeding.
So far, so
It's
good.
very clear, and very nice surgery.
I can only say, so far, so good. No.
So I think for your case that now most of your cases you will do the posterior, right?
Some of them. I also perform the RRP using the post approach, race pairing.
Yeah, but what kind of patient are you going to choose to do the posterior approach?
Small prostate, and
Small
if
prostate.
there is no tumor there, if there's some tumor around the Santorina, Santonia,
with epics, right?
I will skip it.
So what about the patient with very advanced prostate cancer, for example, with T3
If they have advanced,
or with the more than the 20 nanogram PSA level, will you still choose the posterior approach?
来，这边给我提起来，对侧提起来。不用这个钳子，这个钳子是抓不紧的，换一个有齿的钳子。对，换有齿钳子啊。So here is the reflection of the dentabella fascia, right? So I will open.
Okay.
Genitourinary fascia.
Going posterior.
Okay.
你往外展45度往外展哈，这谁在上面？是小调是吗？好的。So I see here, right?
Yeah, it's very clear. Will you cut it with energy?
It's my knife here.
Okay, so mostly with a cold knife, right?
Yeah.
So I saw some of the surgeons would like to use the coagulation during this approach, and some of them use the blunt or just the sharp cut dissection with the dentabellus fascia.
I see here is the opening, and if I down this way, establish the space here is extra fascia, and if I get into here, this is intrafascia. If I open here, is intrafascia, interfascia, and extrafascia.
So for this case, you will do intrafascia?
Interfascia, I prefer. Because there are multiple suspicious lesions according to the MRI, and also in the 5 o'clock and 7 o'clock. So in this case, I think interfascia is relatively safe to try to avoid the post-surgical margin. Hemlock.
Okay, the surgical plan is quite clear in this case.
从这儿插进来，好，上。
Can you say say again why you choose to go in fascia?
Professor Liu, could you please explain again about the surgical plan, the fascia you choose?
I prefer the interfascial in this case because there are suspicious lesion in the 5 o'clock and 7 o'clock in the perifacial zone. So try to avoid the positive margin. I will keep some distance to the capsule. 吸气进一下。
Okay, is Professor Bankrin Ahmed online or
进气拿走。
Professor Bankrin Ahmed, are you online? Okay, I cannot reach.
Yes. Yeah,
okay.
I'm Muhammad Kut. Yeah, I'm Muhammad Kut.
Okay.
I was just asking Professor Liu why to go.
Okay. Okay.
Yeah, intrafacial. And I don't hear the answer, but I think he prefers in this case to go intrafacial.
Yes, it's
Interfacial.
interfacial, not interfacial. 对。
Interfacial. Is the medium. Is the medium part.
Oh, I'm not sure it's T2. Probably it's T3. So I'm not sure.
Okay. Because I haven't get the MI for these patients.
So avoid the positive surgical margin. So there's still some distance, little distance.
Oh, very nice. Very nice surgical plan in this case.
And Professor Leo, can I ask you something about the preference of using cold scissor at this area in the lateral part of the seminal vesicle, or using coagulation? Because some say that the ligature is considered a nerve sparing, and the others prefer to always use the cold scissor while dissecting the lateral part of the seminal vesicle and the posterior ganglious fascia.
We don't have the ligature.
But do you consider ligature as a nerve sparing, or at this part of the nerves you proceed directly with the cold scissor?
It's too expensive for us, so we don't have ligature. It's very practical problem. Here, hemlock.
Medbot,
尽量靠上点哈。
with medbot, they can use harmonic only, not ligature.
Now in China, like the medical insurance policy, we try to save the expense of the patients. So therefore, like in robotic surgery, we sometimes only use a little bit hemlock and also stitches for thread. That's all for all the surgeries. So I think previously we might use the ligature, but only now is the general surgeon would like to use in other surgeons, but in our centers, in urological centers, we mostly use the ultrasound knife. And here in Da Vinci, most of the time in our center, we prefer to use the cold knife or just the hemlock. So now we have another one, so the hemlock could be absorbed within 6 months. So to prevent the complication of the hemlock, because sometimes after a couple of years, the patient will suffer from the bladder stone after prostatectomy. And when we do the surgery to break stones, we find the core of the stone is hemlock. So now we try to switch into is a new version, is a novel with hemlock made with a novel material, so it can be absorbed by the body after 1 year. So the reduced complication with the with the remote hemlock in the bladder in the future.
Okay.
So Professor Sheriff, okay, so how do you feel about the complication, especially like the hernia, the inguinal hernia after prostatectomy in your center? Do you have any kind of cases after prostatectomy a couple of years, especially after 1 year or half a year, with the inguinal hernia after prostatectomy?
I mean, you mean the which kind of hernia you mean?
The inguinal, especially in the right part.
But we don't record this this kind of complication related to prostatectomy actually, but it can be existing from the beginning.
Okay, so actually we in our center we find it's very funny that at the beginning, at the first 5 years when we started with the robotic surgeries, we found actually is around 10 to 15% of the patients will have the inguinal hernia after prostatectomy if we use the anterior approach.
你用你的左手去钳着这个，往
And
左加，
nowadays
好吧？
we have the decreased incidence of the hernia because now we use the retroperitoneal or the single part system, which reduce the incidence of hernia. And we read the papers and all over the world, it sounds like around 2% to even 20%. It's very high incidence, even though with the laparoscopic approach.
We don't have too much cases of robotic prostatectomy right now, but I think that will increase in the coming years. So we don't have actually this kind of survey about these cases.
好，松开吧。
To be very, I mean, few numbers.
Okay. So, Professor Liu, are you going to dissect the urethra part, right? You will rotate from left to right to expose the urethra, right?
I will expose the urethra first.
So, Professor Liu, so my question is, nowadays a lot of surgeons try to sparing the length of the urethra as long as possible. But now my personal opinion is like now it also might be slightly increase the positive margin or the rate of the positive margin when we try to sparing the length of the urethra. And what's your opinion with this step?
I definitely agree with you. To completely get rid of the tumor is the most important task of the operation. So there's no solid evidence to show too much preservation of the urethra, but it really helps the continence after post-operation. So I think here is nearly urethra comes here. This one. So sometimes I open it from here. Here is the urethra, right?
Yes.
The urethra is here. Here. So sometimes I open the urethra from this side, not from the anterior. It's up to the shape of the apex.
Okay, so you start from the posterior part and then you rotate, right? Rotate from left to right.
Sometimes from the posterior. Okay, but this time I will open it from the anterior.
Okay. Will you cut the ligament here across the
I will stitch the Santorini first.
Yeah, okay. So you will spare the ligament or you will cut it?
Yeah, I will stitch it first, then I will cut
Okay.
it.
Okay.
But I will keep the ligament.
You will keep the ligament.
I will keep it. Yeah.
Okay.
4个0的倒刺线，换 needle driver。4个0的那个 vlog 线吧，啊。还行吧，然后那个打开 EB405，我做一个后重建。How is your left arms, Professor Yang?
Now it's better. Now it's
It's
better.
better?
Yeah. I use protection to try to go into the back to the operation room. Okay. Now you use the needle driver, right? Mm-hmm. Yeah.
来4个0的 vlog 线来。
So how many assistants do you have? You have one assistant port, right? In the left.
Sorry.
Your assistant port.
2 port.
2 port. 2 assistant.
I think 2. Yeah.
2 port with 2 assistant surgeon or 1 assistant?
1 assistant.
Okay.
A beautiful girl.
Okay. So you will do the stitch and you will spare the ligament because there's a lot of evidence that if you spare the ligament, it will help for the continence post surgery, right?
You see the resolution is not very high. So this system.
Okay.
It's different from Da Vinci XI.
Still need to improve.
But they improve very fast. They always update. Before last year, I used the 3.0.
Here is the in a lot of centers, Professor, you see here in this step, in a lot of centers in China, we use one hand the needle driver, another hand with the Bible or the mirror lens. So we can spare another needle driver. Some of the surgeons or some of the centers they don't have to spare any expense for the patients, so they can use 2 needle driver. It's more convenient. But now you see a lot of Chinese surgeons are
up who pay the needle driver.
We have to compute the expense for the patients.
Cheaper.
Yeah, it's cheaper.
It's cheaper.
Yeah. Because especially for the French, if you open another instrument, it will be very expensive. It will increase the expense for the patients as well. So you see most of centers. For me, I also use the Maryland fan, and some of my colleagues use the BioBlood as well, and nearly very few centers will use 2-needle driver, because only use this for this one with this step for 20 minutes. It will increase.
If we perform it using DaVinci, we're only allowed to use one needle driver. But if we use this system, we're allowed to use the second one. That is the advantage.
Also, the advantage
It's cheaper.
plan
Cheaper.
with similar function.
Can I comment on this, please?
Yes, yeah, go on.
Yeah, because we prefer to use two needle drivers, because actually taking the left suture is much easier.
连着打3个结，但是我可能还去用它啊，或者打个圈儿也行。
I totally agree with you, Professor.
来剪一下这个。
If you use especially in some of the angles, especially with 8 o'clock to 11 o'clock,
助手剪一下这个线。
use
好的。
the left hand to use the Maryland fan. Sometimes you cannot hold the pillow very tightly because it is not designed for the needle holder. So it's quite difficult. I think only 3 to 4 stitches, because I know for the plan it's not designed for the very small stuff. So if I have the chance or I'm allowed to use 2-needle driver, I will definitely choose 2-needle driver. It will be very convenient to do the stitch, especially we will do the vascular urethral anastomosis.
Actually, if we are using one needle driver, we prefer to take the left sutures with the right needle driver instead of using the bipolar to take it or the Maryland to take it. grip. So actually, it's very difficult to use the Maryland to take the needle, the stitches on the left side. So even we are using one needle driver in order to decrease the expenses, we use the right needle to take the left stitches.
Ah, okay. Yeah. Nice choice. Yeah. We will see how Professor Liu to take it use the Maryland. This is the current status in a lot of centers in China. So the surgeon okay. So Professor Liu, when there's bleeding from the dorsal wing complexes, you will let it go and until you finish to dissect the whole prostate, or you go just to do an additional stitch.
I will do additional stitch.
Okay.
Because part thread broken just now, so I have to 404还有吗？要不然给我直接来个404 vlog 好了。对对对对。
Sometimes I found the bleeding just because that we're extracting the prostate. So the vessel is open, and also if we stop to do the extraction, it will stop. Or when after we dissect the prostate, it will stop bleeding.
啊，接下一个病人吧。啊，接下一个病人了。440的。
Okay, for Dr. Elias Niegas, so do you have any comments about this step? Because some of the surgeons prefer to do this to suturing the DVC in the beginning, and some of the surgeons like Professor Liu will contribute later. So what's your opinion and what's your Professor Elias Nyeka online still? Okay, so for Professor, what's your opinion? So will you consider the DVC as the first step, or you consider when you dissect it or cut it?
I usually start with getting the sutures in the first step, but if I mean during the section bleeds, I continue until we finish. Then I go back to check it and give more sutures.
Okay, okay. Since for me in our center, in our center, if we do a routine procedure, normally we will try to do the stitch at the first step when we open the endopelvic fascia, and then we do the stitch with the dorsal vein complex. Or, but if we try to sparing the NAD for the patients, or we do to sparing the tissues with patient, we directly start with the prostatectomy. Now we will do in the end. So it depends on the stage of the patient. If the patient is young, with 55 years old, with very nice, very good sexual function, and only one stage with 7 or PSA level with 5, we'll try to do the VIP procedure and try to sparing the MVD, and if we try to use the intrafacial approach, we will try to we won't open the endopelvic fascia in the beginning, but sometimes we'll still for example, like this case, when we have bleeding, we still have to do the stitch. It depends on sometimes the size of the DVC, or if the patient are very obviously, sometimes we don't have very strong bleeding, but sometimes it's very strong. We have to do an additional stitch in the end. So Professor Leonard looks much better.
I don't know why I prefer the 40
Okay.
than 30.
So can you share us about the techniques here and the direction you're doing with the stitch to not only to stop the bleeding, but also to you start from the downside and go into another angle and to do the stitch, right?
Before you expose the user completely.
Very nice stitch. Now there's no bleeding.
Maybe bleeding future. Sometimes there's no bleeding, and but after my future bleeding comes.
Yeah, I think it's because of the pressure of the gas in the abdominal cavity sometimes.
换招，细细吸一下，
Yeah, yes, you are absolutely right. Sometimes keeping the gas with high pressure decrease the bleeding, and this is a trick in order. Sometimes you don't prefer even to take a stitch and just keeping the gas up and stop suction. This is one of the tricks for the assistant to decrease the suction, because the suction decreases the pressure and causes more bleeding.
Here.
Yes, 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 Dr. Long.
Here.
I agree with you. Sometimes we just increase the pressure and we stop the procedure for a couple of seconds and it will stop bleeding. And sometimes I feel like because of the direction of the dorsal vein complex, because of the direction, when we will give the contraction to the prostate, then you see it will be increased bleeding, but if you release the extraction of the prostate, it will have stopped bleeding in a very fast manner.
Yeah, 我在里边嘛。
So, so Professor Liu, nowadays I see some of the surgeons try to sparing the orifice of the injection duct Now, and what's your hobby here? Will you spend the opening starting from the ejaculation part? Will you spare it? Or what is the landmark with your urethra when you try to dissect with the prostate here?
In the landmark of the urethra.
Yes. Yes.
Is the muscle.
Mm-hmm.
The color is different. Okay.
Very nice. It's very, very long and very nice urethra.
换吃真气了。这个左边这个不管用了，这换挡的换不了啊。来来来。
Okay, now Professor Liu is going to do the vesical urethra anastomosis here. And what kind of vlog do you use, Professor Liu?
What?
3.0 or 4.0 vlog here for the anastomosis.
4.0.
4.0. Okay.
4.0.
Okay.
I will check if there are any bleeding.
And is this
okay.
85 vlog?
Bleeding.
85 or 2-1? So what about the vlog with the needle?
4.0 vlog.
Okay.
I need to check there's no bleeding. Okay. 剪掉它好了。剪掉它。
Okay. Now I start to do
它。剪掉它。剪掉它。
nice. Looks nearly no bleeding.
Yes.
So Professor Liu, so how long will you put the drainage post surgery for a couple of days?
For 3 days.
For 3 days?
2 or 3 days.
Okay.
And they will,
Okay. Okay, so for Professor Moret, how long will you put the drainage normally for the patients post surgery with prostatectomy?
We usually do it 4 to 5 days.
4 to 5 days, okay. And what about the casture for 1 week or 2 weeks?
for me, 10 days.
10 to 14 days.
Okay.
减掉它。
Yeah, we are very similar. In our center is around 10 to 14 days. Okay, so Professor Liu, we have some audience ask you about the stitch you use. Could you explain a little bit about the needle you choose and the suturing use? What kind of suture you use?
This one.
Which brand? We love.
Resolve.
4.0, right?
4.0.
Ready for the next section for the latest surgery.
这个擦一下镜子来。
Okay. Okay, so okay, I think now we will still keep
3个0、4个这个什么这个310。
and then we will quickly switch to the next session. Let me, okay. So, okay, so in this session, we already see Professor Liu Chen with a very nice, and there's no bleeding surgery. So, and also it's very nice to co-moderate with Professor Sharon Moret, and also Professor Niega, and also Professor Rom, and also we appreciate the chance to commemorate and see a very nice prospectomy from Professor Liu Chen. So now I think Professor Chi is already for the next operation. So let's switch to our next session. So the next session will have other operator from Professor Chi Fen, and our moderator will be Professor Cui Li from Shanghai General Hospital, and Professor Mohammed Omar, and Professor Dr. Elton Blachus, and also Dr. Elias Niega. Okay, so is Professor Cui online already?
Yes. So that my camera. Hi, Dr. Lee.
Nice to see you, Professor Cui.
Yes, that's to see you again.
Professor Sue, would you like to introduce the moderator for such a session?
So we begin now.
Yeah, maybe we can switch
Okay.
to the next.
So we are ready in the operation room.
The room, the OR.
Let me just switch the online showed from the robotic surgery room to our ordinary room.切换一下传播视野吧。
Okay, Professor Chi, can you hear me?
Yes, I can. It's very clear.
Sure, okay. Yeah, could you see the video? Could you see the video?
Yes.画面很糊啊。
Yeah, a little bit not so clear. 能不能换个镜头啊？换个镜头，对，镜头。
不然你是不是调了一下带宽？这个画面太糊了，根本什么都看不见。
啊？是因为我这个镜头的问题，还是你那边？
不是我镜头，因为我看都看不清楚，我这边不知道是我的网的问题还是我的网。
那可能是你网的问题，我看似乎还行啊。Okay, now what's that?
我们那个刘主任那边机器人很清楚，然后你那边好像不是很清楚。
要用适宜南院那个画面固定一下。
How can I start?
金老师，要不等一下吧，其他两个人好像还没上来。
你说另外两个 moderator？
对。
没事，我就做吧。他什么时候上来，我们什么时候开始聊就行了。
那我就不开场。
哎，你哪里编资料啊？是 OK。
我有那个他有资料。
Do you have the information, the patient information?
Who can introduce the page? Who can introduce that page?
I can reduce the pace. So okay. I think the Professor Muhammad Omar is online now. Hello.
Good morning. Hi, how are you?
Good. It's afternoon here and good morning.
Good morning.
Yes. Can you see the screen clearly?
Yeah, I guess you can hear you well. And it's good morning from Egypt. I know maybe it's after afternoon in China.
Okay.
Yeah.
So I think I have now.
Professor C, could you please, Professor C, could you please introduce the information of the patient?
Okay.
Do
is a BPH survey, and the other just wait a minute. I just check the information here. And the chip company is that this urine for 2 years and aggravated in the past 1 month. So this patient has high hypertension and diabetes also. The patient developed frequency, urgency, interrupted steam, and noturia for 2 years, and negative for the hematuria and fever. So the IPSS is 22, and the quality of life is 6. And the BPH, the volume of the prostate is 50 milliliter, and PVR is 80 milliliter. The Qmax is 9. So we can also that is the brief information about this case.
Okay, so today the equipment, our serum laser is made in China from Riken company, and my setting is for the high grade model. What the power is 40 watts, and the energy is 1.5 joule. So for this patient, I think we have exposed the surgical capture, but it is, looks like it's not so smooth. So the patient have many nodules. Yeah. So this is a very metronome, and let's identify the external ureterus sphincter. It's here. Yeah. So we can find the surgical capture just behind the vermentinum, and use the peel technique for this case. The rather spray as a rich. Yeah. For this patient, another condition is this for because the the poor condition of the reservoir. Then we, yeah,
In such cases, you may prefer to have the 22 French sheets. Gonna make your life easier.
yeah,
With almost up to dilatation.
yeah. So actually, I think if the patient have the very bad urethral condition, it will be challenging for us to do the operation. Yeah, like for this patient, so the capture is not so smooth.
You are using
Many
mode or continuous mode.
yeah,
It's I think it's a continuous mode rather this layer.
so this is a pass mode.
Fast mode, yes.
Oh, a pause mode.
Yeah, yeah. So we can use cutting the position and the fuse combine the fuse technique to extend the plane until to the plane neck. So this another noodle here. So for this patient, you have many blood supply and many noodles. Because for these cases, the volume of the process is not so large, about 50 milliliter. Yeah, but like PP, a little bit, because the IPP, I think, is
Mohammed, good morning. Good morning, Dr. How are you? Fine, how are you? Good. I was waiting, Professor, if you hear me, I was waiting
Professor.
We have two other moderators online. Is Dr. Muhammad who has just asked you the continue this parsley. So we also have another friend. It's Dr. Bob Trias. I don't know what's it good or not.
If you say
Okay.
like this, it seems like I'm from Greece. Nationality is fine. Yes. was willing to ask Professor, what are your limitations in volume with patients with thorium? Like this case, it's medium case of 50 gram.
Yeah.
What are your limitations in volume?
Okay.
So
Professor.
I think the Dr. Chi
I can answer you. So I think it's dependent on how you train your trainee or fellow or whoever to use the device that they use. So I used to use sodium use and now I use Bible, I use volume, and I go to any side. But the only it's a matter of training. So as much as you have good training, you can use any form of energy to have any calculation done. Maybe sometimes the problem was gonna be with how to deal with some difficult points like having used up to 250 gram TFL is more than enough for controlled bleeding. The problem usually is the smaller glands, not the bigger glands. So usually I think that the difficult surgery is a small one because the brain is less developed and you find yourself difficulty trying to figure out how to separate the adenoma from the capsule. I think the difficult prostate is the smaller prostate, the difficult vein, the bigger ones are higher.
Totally agree. Thank you, Professor.
In my personal appearance, we can just up to the 300 gram prostate can. We can also use this sodium incubation. So also we can choose the Medigan or another method to remove the enlarge the prostate tissue. But in my opinion, less than 300 is okay for us. Especially when you're very familiar about this technique.
Usually, I think that the TFL is different from holmium in how to avoid child mood to happen and how to use it with that clean outcomes, clean fossa, clean So the muscle mood is going the time and keeping the fiber away, little bit not touching. These two things is your way to avoid much showing during TFL initiation. The effect of hemostasis is very, very excellent now in regard to the sodium yak in the past. So the sodium yak did have a problem with hemostasis. I think TFL have overcome this problem.
Okay, so I think maybe due to the internet problem, sometimes I cannot hear you so clearly. So for this patient, because I always use the two-lobe technique or three-lobe technique. I don't like the unblock. I don't know about your how about your opinion, Professor from Africa, Professor Cream. For this case, I use the three-lobe technique. I will remove the middle lobe first, and then I think after the removal of the middle lobe, it will make it easier for us to remove the lateral lobe. Because we have the enough space and the clear clear sight. Michelle.
So, which you prefer the two friends from Africa is the block or just the straight lobes resection? Prophet Muhammad, do you prefer the unblocked one or just use the three lobe or two lobe resection?
I think the technique is coming with your learning curve. So the best in my understanding is the implant. So it saves time, and actually this is gonna be the standard maybe in the future after everyone standardized the technique and knows that he is running in a transitional mode from three loops, two loops, then complete implant. But sometimes you may shift from implant to two loops or three loops maybe if you are in your learning way, you start with the three loops to have plenty of time to figure out is this a plane or not, and to control reading, and maybe if you are taking a lot of time doing something, you can shift from technique to technique, shift that to finish two loops this time. Many things are controlling this, including the difficult lane acquisition, but I think Block should show in the research and in the clinical trials shorter time because we are not like spending time in doing a lot of 5 and 7 and then we don't need this. We just need to go below the adenoma, encircle adenoma, and let it go inside the bladder. If we did this, it should have this time. But some prostate may be very big that you cannot introduce an in-block way. At this situation, you have to open the book, and that's what we say in block with open books, that we open the commercial at 12 o'clock to make the adenoma as a butterfly, not circle, because I cannot introduce inside the bladder if it is completely circle. I need it to be opened and then we rotate it and then introduce it loop by loop. So I would abandon in-block if it is a very big one, and I think I may do this after 220, 200, because up to 150 I still could do block easily, but also there is another factor. Am I controlling the bladder neck and preserving it or not? If you preserve the bladder neck, it's more difficult to introduce larger adenoma. If you don't preserve the bladder neck, so now it's easier for you to introduce a larger adenoma. So yes, some surgeons can do in-block even with larger than 200 because they sacrifice the bladder neck. I usually love to leave the bladder neck intact because this improves the continence and prevents the early urine sensation that happens when you open the bladder with the fossa and make them a continuous channel, which is not the best thing.
Yes, totally agree with you, but some depends on the patient's status and the big one. If you have the big one, and we need the 2 lobes or 3 lobes is easier. So what about you? What's your opinion about this topic? Dr. Bob first.
I totally agree. It depends on the learning curve of the surgeons also at first, because there is centers who started with three-lobe technique and continue to do it for all the cases. And 2 or 3 years after they started to do the on block technique, but I think that when there is a huge prostate that you can't go for an on block technique, you can go with the 2 lobes or 3 lobes technique, and as Professor Mohammed said, it's important to let part of the commissura for the continent. So here in Algeria, most of them are using the three-lobe technique, and there is some guys who starting to do the unblock technique. Also, we are pushing, I think there is cases of 250 cases that are done here. We have not the same experience than you in China, or Professor Mohammed is an expert in nucleation, so that's my point of view. It depends on the volume of the prostate and mostly the learning curve of the surgeon. We need to choose the technique that fits us, that suits us, that how we can do our surgery in the good way. But definitely, if we compare results, the unblock technique is better.
Yes. So do you choose laser surgery purely, or just use the bipolar plasma enucleation in your daily?
Cases here, Algeria is bipolar. There is some guys who are starting to do laser, but the most of them was bipolar. We are starting the education laser in Algeria.
So, as an expert on the bipolar plasma surgery, so when you watch this sodium fiber laser, what's the most obvious differences you notice? Tissue cutting or just the mitosis?
It's better. It's obviously, it's clear that it's better, it's easier. I think that we need to go with time, we need to go for the laser.
Professor, how about the continence? If you use the bipolar or enucleation?
You need, I think, again, are treating your patient with. I have been using sodium as my starting infusion, and then I went to holmium, and then I went to bipolar. I was fortunate to use everything, and I know that my confidence rate was better after I become expert. So this is the point that I need to clarify. It's when you complete your learning curve, you are dealing better with the sphincter. You know how not to use bigger sheets with a tight urethra, to put a lot of gel, limit your movement to the lateral side because this is a problem going to this side and to this side. All these things with the early apical release are going to control your confidence rate. And you cannot control all these factors except when you have passed at least 100 cases. So if we made a study about the confidence rate with every expert, you would find that at his early learning curve, he have a higher stressing confidence. But after a while, when he passed his learning curve, now he has a better confidence rate. So with me, it's not a matter of bipolar or laser. It's a matter of when I become aware about what I'm doing inside the whisper, controlling all the factors to get less than 1 to 2% stressing confidence if I can. And also, there's other factors that you cannot control. One of them is the size of the prostate. Like when you're having a bigger gland, now you have to do bigger lateral moves. These lateral moves sometimes are able to control or to cause a weakened skin. Like you are pushing over the sphincter so you go more lateral. And this definitely gonna increase your stressing confidence rate. So sometimes even with a bigger gland, even if you're using laser or using bipolar, you still have stressing confidence. And other factors, like trying to have a better hemostasis, to have a better vision all the time, to avoid vigorous movement, to avoid pushing the adenoma inside while it's attached to some parts, to completely separate the early apical part in the right way. All these things is going to govern stressing confidence happening or not. So bipolar laser is not a matter of the electrical or the laser current, it's a matter of how to use it.
Yeah, I would say that we guys prefer laser. So, in my personal opinion, I think the laser is actually enucleation as a continence compared with bipolar plasma enucleation. As you said, the learning after you have crossed the learning curves, maybe the economies just rate is lower, but I think the APEC resection is very important to protect the continence after the surgery. So we can see Dr. Jin's strategy, and when we see just cut the apical area. So on the right lobe.
Yeah. Let's double check the sphincter here. So there's a nodal, so another nodal here. Let's double check the sphincter here. Okay. So now it's a dissection of the apex. Actually, I think it is the most important step to control the continence after operation. So with a swim laser, we can dissect the apex very shortly. So there's no tight here, and we can keep we can protect user. I think use a swim laser. We can protect the sphincter here much better than Holem or Biopla, because the Sulum had the very excellent cotton positioning, effecting, and also it has a very excellent hemostasis efficiency. Yeah. So use the technique. I think they have almost no any affection to the sphincter.
So Dr. What's your opinion, what's your experience about the learning curves? So how many cases if a beginner want to handle this technique, how many cases will be better?
So you ask me or?
Yes.
Yeah. I think for learner, I think the learning curve is very important for doctor or urologist to do the enucleation say about 20 cases, it's enough. Although I don't think I don't think I think you are better to use not so large prostate, like about the volume of prostate. It is better from uh, 50 to 60 milliliter. Actually, I can exchange the idea to many doctors in China, especially the young doctors. Most of them think that the swim laser, the SULIP, have the very short learning curve.
So as we know, the HOLIP has a very large cases to, of course, the learning curve. So what's you think the most difficult step for the beginners? The apex or the bladder neck or the label resection? Which one you think is the most difficult for the beginners?
I think the most step, yeah, the trick exposure is not the hardest. So, the hardest step for the sort of beginner, I think, is decision the apex, because the decision of the apex is most important step related to the continence after operation. Okay, I almost done.
It's very quick.
Yeah, so this is characters of the Zoom laser. We can say that the hemostasis efficiency is very high and almost no bleeding. And also, we just cut the tissue. Actually, for these cases, the capture is not so smooth. So use the high catching efficiency. We can very easy there's a vessel. 帮我挤一下，帮我挤一下那个，挤一下那个水。So let's find the vessel here. Okay. Oh, okay. Killer. So, yeah, so you can see the hemostasis efficiency for Sulum is very high. In this aspect, it is very good news for the beginning leader.
So we can see the perfect bleeding control about this laser. So what's the usual catheter duration after the surgery? Just 1 day or 2 days or just 1 week?
Sorry?
What's the usual catheter duration
Are you talking to me?
surgery? Yes. So you are in the hospital, so after the surgery, the patient have the catheter. So how long they will have this catheter? 1 day or 2 days or just 1 week?
It depends. If the patient has a very small prostate volume, we always keep the catheter for at least 1 week. For a middle or large prostate, we will remove the catheter in 48 hours.
So what's your experience in your hospital, Dr. Mohammed or Dr. Walters? How long has the patient have?
Usually I don't keep the cluster more than 24 hours. This is maximum, except if I know that this is a weak bladder. So then we are talking about adding a mistimone for contraction of an atonic or semi-atonic bladder. But if there is no reason that I makes the fossa is not the bigger one, but more irritating, and the irritation is gonna lead to having a more pain and this successful trial of maturation. So to overcome this in the smaller class, you may try to extend the time of custard. But for me, I think this is gonna be against the principle of nucleation. Like you want to show the world that nucleation is the best when we have the complete removal of the normal, we should have the immediate effect of good flow. And I think it's something related to how much we remove from the adenoma, which is the a point is linked to what you asked about the learning curve. Usually you may have 10 cases and you become doing initiation, but how much did you leave of the gland stuck to the capsule? Because sometimes during initiation you may leave some part of the posted. So after 10 cases, you still do nucleation, which is maybe incomplete. But after a 20 to 50 cases, now you are doing a better understanding of which part is gland and which part is capsule, and you are able to remove it more than 95% of the gland, which I should say is successful. But when you have an intuition and you are leaving like 24.5% of the gland stuck to the capsule, this is not the best intuition. And I know there is many factors control this, including the area of chronic prostatitis, the maturation of the gland and the gland, because it's sometimes stuck in some area you don't want to use much power and do a lot of movement trying to get it out. So again, I think it's related to your understanding of how to completely remove the adenoma. If you remove it completely, you're gonna have the fortune to remove the castle maybe even after 4 hours.
Yes,
I agree, but you know, there is this fear, especially with the people. I don't talk about professor. I think with people who are starting enucleation, they don't have this courage to go for removing removing it in 24 to 2 days. What I ask you, in cases with like this ultrastructure, do we need to let it more days, Professor Mohammed, not to remove it in 2 days?
You know, the difference between 3 days protocol or 7 days protocol for structure restore is debatable. Some say it's 7 days, some say 3 days. But definitely if I having a sample structure that have been dilated successfully, I may extend to the 3 days. But usually, I would have different size scopes because it's very important to have the backup, the 22 in your shelf, because some user will not accept the 26. So in cases when I see it is not structure, it is a tight user, I would refrain from using 26, but because the 26 itself could cause trauma in the future, and it doesn't matter was it laser or by volt, using a larger receptor with the tight user is a problem. And I think whenever you use do a lot of cases, you would have from 5 to 10% of cases where you shouldn't use the 26. You should use the 22, and if you don't have the 22, I think you have to do a regular classification to avoid making the trauma with the 26 itself.
Okay, thank you.
So my question to the surgeon, I think is what is the merits and the drawbacks of using TFL versus bone meal? Like, give us your experience. What is the things you like? Very nice picture of the sphincter. This is actually very nice. What are the things you find better with the sodium, and what are the things you find better with the bone?
So actually, the question is the differences between the sodium and the helium.
Yeah, for him in his the surgery, what is the things you like when you are using volume, and what is the thing you find better with the sodium or the TFL?
In our center, the sodium is the most, the majority of all for the majority of cases, we only do the few volume. Actually, other centers if you have the hollow laser, as you know, all the hospital has a hollow laser for the stone treatment. So not all the hospitals have a solo laser. So I think these two lasers have different have several differences. It doesn't mean which one is better, but it means which one you just want to you have the more experiences. So in our cases, in our centers, volume is the sodium is the majority one. So, do you have any comments about the difference between the volume and the sodium?
Actually, I think both of the two different the method have their advantages. Like the volume, we have it is very easier for us to expose the capture, surgical capture, but for Sulum laser, for Sulip, the most advantage of the Sulum is excellent hemostasis efficiency, and also we can do very precise operation on the like the decision of the apex, and also when we operate to the brain neck, we can keep it very engaging the neck. So, so actually, like Dr. C to us in our center, we just published with the Sulip, and especially for the very large prostate with very rich blood supply, I think this Sulip will be better for the bleeding control. Is
I think the whole
also the muscular is also made from Rican. I think it is very high efficiency. Yeah, sorry.
So I think the Holly is more pulsed and mechanical. The solar laser, when you just perform it, it's more you can feel more smooth and more punctual. continuous. And so the bleeding control is better compared with Holly.
Yeah, sure. Totally agree.
So I think this case is down. So
Yes, wonderful, wonderful.
Yeah.
Yes. Very quick, very smooth.
I don't know.
Very, very nice surgery. Congratulations.
Thank you. So let's double check the bleeding. So we were I always 哎，这是8乘40，40吗？Okay, just go to now. At the end of the operation, I will use 40. I will use a low power of sodium like the 40 water 40 watt to double check the bleeding. And also double check the sphincter. Especially in the polishing of the brain neck.
So I wanted to raise this point for the beginners is that using
For this case, I will
yeah, using TFL is gonna make your life easier because it contains the merit of shifting between inoculation and resection. As we said in the bipolar inoculation, sometimes if you don't know how to do or complete the case of bipolar inoculation, you will shift to do bipolar resection. It's the same here with TFL. In any case, when you are a beginner and you cannot continue in the right lane and you feel uncomfortable with what you are doing, you can shift with section. This is the merit that you have in the TFL, you don't have it in volume. The restriction mode on the TFL is magnetic. So this is one reason that you may start using TFL in your cases, and if at any minute you find yourself uncomfortable, you shift from inoculation to inocular section. You can bypass part of the capsule that you feel you may include a perforation and just resect here to avoid doing a perforation, especially at the point where there are curvature in the fossa. For the question about what are the difficult points for the beginners, usually there are several steps of difficulty. Number one is how to continue in the right lane all the time. This is one of the most difficult things. How to rotate from the base to the top, continue running in the same plane, not shifting between inoculation and nuclear section. The other is at the 3 and 9 where you face the leaders, but I think it is easy now with people. You can see that the pace is very nice and the beating is nearly very slow. Also, the last point, which is very problematic, is how to avoid going below the bladder neck and causing perforation at this place, because this is the second curvature that you usually, if you're not aware enough, you may have a perforation or may go subcapsular trauma. And I think if you finish these 2 points, how to run in the right lane all the time, and how to avoid problem at the bladder neck, now you are ready to have completed like 75% of your learning curve. The last thing is how to leave the sphincter mucosa intact. As we see here, the surgeon is really experienced and he was able to avoid disturbing the mucosa, leaving the mucosa perfectly nice. If you wish to do this, this is the end of your learning. And actually, congratulations for the very fast and nice surgery, Professor.
Yes, I think Dr. Muhammad gave a great summary about this section. You can see the sphincters very good
So
now.
just double check it. Yeah, that's no problem. Okay, now I have completed this operation. Thank you for your processes, your moderate. Yeah, so let's see. So this is the structure of the urethra. Yeah. So for this cases, maybe I will remove the catheter 1 week later. Okay, thank you guys.
Thank you. Thank you for the surgery.
Thank you, and congratulations for the nice surgery.
Actually, I have one last question for you all. It's about the median lobe, how we deal with the median lobe. Is there some tips and tricks?
Okay.
So, median lobe is according to its size. So take care from the median lobe when it is smaller one. Try to include it to the other one and make 2 loops technique. If it is bigger one, now you can do the 3 loops technique. So this is the first moment. Avoid trying to go in below a small median because this is not usually you find a median. Sometimes you find two lateral, sometimes you find a very small median. At this time, just do 6 o'clock incision, don't do 5 and 7. But if you have a big one, now this is the first thing that you can start with the median only. Do 5 and 7 and then continue to connect these two incision at 1 centimeter and above the view. Because sometimes if you are having an obstructed seminal vesicles and large adenoma, you may open the ejaculatory duct while trying to connect these two lines. So it's way to happen, but still it's a problem. So avoid this by going 1 centimeter above the view to avoid injuring any ejaculatory duct or seminal during connecting the 5 and 7. Now use the big obstacle to elevate the median to be sure that you reach it to the most anatomical part of the median because median has fibers attached to the view, and at this part it's difficult to find is this fibers are the fibers or this is the capsule. I'm using a bit of this elevated to be sure that you reach the right plane. After this, now it's fine to complete because this is a straight up to separate the normal from the rest of the capsule and the balloon. This is what I can say about how tricks and tips to avoid making a problem during mediation.
So to progress, so yeah, to progress, just I have a last question about this. So in your hospital, do you have tried to switch the bipolar to the laser? Holic or solium or solium is okay. Do you have any try about this?
Sometimes I use bipolar and laser in the same cases. Like you're gonna find on my Twitter today, I'm gonna publish a case when I use bipolar for one loop and laser for the loop to make the world see that you can shift between the two loops and two techniques, and you can have the same result with the two techniques. And I think it's very important to know how to use both because sometimes if you have malfunction with one of them, you could shift to the other. And I like the idea that I can use anything anywhere. Sometimes when I go to different hospitals with some of
triggers? You haven't tried to yeah. Okay. So what's your opinion about the main barrier to adopt the whole the laser? So is the laser platform cost or the fiber cost or the training or the equipment?
As I told you, we have not many years of experience in inoculation. In Algeria, we just started a few years ago, and I think that first step was with the bipolar because it was available, but now there is two or three departments that have laser and started to do it. Mid department will start to do it soon, so that's it. It's not a matter of cost. It was a matter of time evolution. That's it. And I think it's inevitable. We have less time, better results, better hemostasis. We'll go for it soon, very soon.
So about the future of the BPH surgery, we know we have a lot of other minimal invasive methods recently, such as the Resume or the Urolift. So do you have a trial of this new technique in your cases? The Resume or the Urolift?
Not Urolift, I did the Resume. We do Resume, but we select our cases. I think that Resume can't be done for every patient. It's not the technique for our prostate BPH. We need to select our patients, explain them, because Resume will not have like Professor Mohammed, they remove the catheter 1 or 2 days after, and we have the results. The results will come a month after. That's it. We never tried the Urolift, only Resume.
So when you just choose the cases for the Resume or the bipolar, what's your main concern about how to you choose which one? If you have a patient, you will recommend the Resume or just the bipolar first?
First of all, we started to do Resume because it was a new technique. So we wanted to know. We started to try it. cases with small prostates and cases who want especially to have their to preserve their ejaculation, but and we need to know that it's surgery that costs. So the cost mother is very important as an issue here, or not all patients can do it.
So what about you, Dr. Muhammad? Do you just do the invasive, non-invasive techniques?
I have to be honest. We have economical issue in our country. We are 120 million, and not everyone is able to withstand the large, expensive resume everywhere. This is number one. Number two, most of the patients may not be accepting the late improvement outcome of resume and not accepting the possibility of another surgery after 3 to 2 years if it is a bigger than. So I will explain every merit of every technique for the patient, but when we are talking about larger glands, we are talking about people in a less covered insurance and have a problem with paying for the hospital. They are usually entitled for having a surgery that leaves their problem and not to be done again. And this time I will choose neoplasia. But if the patient is younger age and he is entitled to have preserving the ejaculation and he is able to pay for the resume, I give him all the recommendation if he accepted with the delayed outcome and the possibility of another surgery of resume or whatever after 2 to 3 years, I go with resume. But the problem is, what after the resume era, like we are going to resume our occupation in the last 5 years, but we're gonna find little bit difficulty in treating this patient later because some patient will have more infection due to the resume effect. Some patients have a problem in obtaining the brain during infection. Some patients having a sanity between the glands. Some patients gonna have a colonic contraction, especially when we use resume in the smaller glands. So I think we are lacking a large size trial cohort study to see what after resume, like what surgeries have been done and what was the outcome of the resume and how many patients didn't continue the 3 to 5 years with full and did have to do the definitive surgery after Zoom in how many months? We need more data, and until we have it, I think we cannot have a lot of experience. But as patient, as I said, it's a matter of patient counseling and show decision and what was the decision with the patient he chose, I would go with as long as it is the right decision.
Yes, very good. This section, I think, is the end of this section, and we have in this section, we have the excellent summary from Dr. G, and we also have a topic about several different discussions about the laser, new technique about the defect treatment. So thank you, Dr. Mohammed, and thank you, Dr. Bob Peters. Saying we can move to the next section. I think the next section is the student surgery. Thank you. So I will introduce us the next moderator of the next section, Dr. Yu Xiao, and Dr. Yu is online.
Dr. Yushal was working online 10 minutes later.
Okay. We have also other two friends from Africa. It's Dr. Amani Audio Hani, I think. And the next one is Dr. Alan Truer.
Professor Aman, Professor Aman and Professor Shimura is online. Both of them from Africa side.
I didn't see the camera. Okay.
There we go.
I can see you. Yes. So I think the operation room is here. I think the operation room is just prepare for the next surgery. Maybe we can just wait for a few minutes.
Okay, I'm just doing a little setup here. Give me a second. Right there.
Okay. Dr. Amani is also online now.
Yeah, hi. How are you?
Hi, nice to how are you? And I think the operation room is just make some preparation for the next procedure. So maybe we can wait for the few minutes.
Okay.
Okay.
And
Professor Sidney, maybe you can introduce the devotees to the those of the professor and to the audience. And can you see their CV online?
yes, we can see the CV online now. I think it's my great honor to introduce Dr. Allen first. I think he is the president of the Authority of Urology Surgery of Zimbabwe. And also he have a lot of memberships in the AUA and the African Urology Association and also the Surgical Society of Zimbabwe. And his professional responsibility is on the hollow laser electricity and the storage surgery. So welcome. And the next one is Dr. Amani. And also the professor and also he is the head of the urology and the private hospital. I think it's from Morocco.
Yeah, Morocco.
Yeah. So it is also the former head of the Department of Urology and the military hospital, Milsey, and yes, and also he is also the professor of urology at the medical school of the physio, I think.
Functional.
Okay. I expert in the urology and the functional urology. I think the Chinese colleague of this part is Dr. Yu Xiao. Is Dr. Yu Xiao online?
get online. It will be online at 10 past 4.
Okay. So the operation room is ready now for the next part.
We are in preparation and like 5 or 6 minutes.
So the doctor we need to wait maybe 5-6 minutes for the next part.
Professor Isha, 李教授，李教授，
我这个地方有点散。喂，
李教授，那个非洲大概已经在线了，然后Dr. Allen 和那个和那个 Professor Amati 都上线了。
那是谁介绍那个邵一主任呢？
我们请的手术室有一位介绍助理的老师介绍一下。
哦，好的，好的，好的，那我们就是等着邵一主任的表演手是吧？我们就主持一下，好的意思吧？
好的。
那这个中午怎么拿耳机连不上？我觉得奇怪了，这搞清楚，真的，所以有时候真的多记一点啊。那个，那我就等通知了，你们主持人他会先介绍病例吧？好的，好的，好，谢谢。Next case is this case is 35 years old male with recurrent left back pain for 2 months, and the patient with left 12 millimeter stone and the left lobe extremities with 1.2 millimeter stone. And the left test shows the urinary analysis and the urine culture with negative and the diagnosis is left
your result actually with left hydronephrosis and left renopathy.
Hello? Hello? Would you hear me? Yes. Yes. Okay. So, someone introduce information of the patient. So I'm not not here clearly. So, what is the diameter of the stone? So 1.2 centimeters. 1.2 centimeter? Yeah, 1.2 centimeter. Okay, you read. And I think that's the one in the ureter. I think the one in the kidney is about the same size. Professor, is that correct? Okay. The ureter stone and with the kidney stone, the two stones, the same patient. Yes, the same patient. Shao. We didn't have connection with the doctor. Sorry, do some preparation for the operation.
Yeah, Professor Shaw is the chief physician of our institution, and he is the director of the Department of Urologic and the upper urinary tract extraction, very famous surgeon in this field.
那个工作人员那个到时候在手术室吧。
在的。
邵教授
没有给到邵教授，画面和那个声音还没给到邵教授。
邵教授讲了这个病例以后，邵教授能给我们介绍一下他的这个手术。
好的，我们把邵教授话筒打开。
Professor Yu, can you hear me?
Yes, it's very clear. So you
Okay.
Plan for this patient.
Oh, no. Professor Yu, can you hear me?
Yes, yes. Voice.
Oh, yeah.
Your plan for this patient. What will you do?
Okay. This patient has对啊，这台也行的呀。为什么？Yes, this patient has upper uric stone. Yes, this stone is 12 millimeter, and this patient also has renal stone in the
只觉得你的声音能不能把你的外形或者你的内能不能也给我们展示一下？那个 OK， 可以了吗？Now you can hear 外景 Can you hear can you see me?
Yes, we can see you and we can hear you.
Okay, it's okay. 吐点水 Yeah, now we can see the stone clearly. Yeah. And now
Before you start, though, could I just ask, in China, do you normally pre-stent? Do you normally pre-stent your patients or not?
No, normally no. Just we do the just the one stage. Yeah. I think more than 90% we can complete the IS the one stage. Yeah. So before I put the sheath, I will use the ureteroscope to confirm the ureter condition. Yeah. So now I find this patient ureter condition is not so very difficult. I put the 11 sheets.
Okay.
The inner
Do you have a safety wire or not? Do you have a safety wire or not?
No. Normally we don't use safe wire. Yeah. Now I can begin to use the volume to laser. This is the first time I use this laser. Just Chinese friend King. This is the second generation laser machine. Yeah.
What are your settings?
Setting I setting 拉下。I setting one, two, and yeah, 12, 20 frequency. kids.
Yes, yes, yes. We use the suction sheets. Yeah. If it is impossible, I will put back this stone back to the kidney. Just I think to lay the stone is more safe. Safe. Yeah.
So, Dr. Sao,
Yeah.
Professor Sao,
Yes.
I have a question. So, how, what is the choice when we perform this operation? The column and the theorem later. I think maybe you have more choice in your hospital, maybe. So what is the condition you choose column, and what is the condition you choose the theorem?
Okay, this is a good question. In my department, we have the volume and sodium. I also nowadays I also do some clinical research. To be honest, I find whenever use the volume or sodium, I think the operation time and the stone-free rate is almost the same. So I think when we use the fans, maybe almost the same, almost the same. In the future, maybe some urologists will use this technique. I think sodium can dust the stone better than the volume. Maybe at same time, sodium maybe it is better. But now, when we use fans, I think almost the same. And if we meet some hardest, how to say, to hardest stone, maybe volume maybe is better.
Depends on if the stone
Yes. Yeah.
So what is the advantage of the second the new generation machine compared with the old generation?
Okay. This is a very good question. Yeah. I also asked the company why you this new machine. I find because nowadays because we use fans thing we can use enough irrigation. So maybe we can set more high energy and thing we can be quick to complete the surgery. Yeah. So I think because now good irrigation we needn't worry about temperature. More energy. We can set more high energy.
Professor, so there are other lasers that have the dusting capacity and ability. Do you have any comment on, using the laser that you're using that doesn't have that ability? Does it really make that much of a difference?
To be honest, nowadays I think for me, I think the thing or fragment when we use fans, I prefer to just fragment is better. Yeah, just for just like this. Shisha. Maybe when after in the future when we use this technique, maybe that thing is better.
Yeah.
When we use the fans, we needn't equivalence. Yeah, for need back set the soil 看看行不行啊？这个光线。Now I because now the stone is in the carousel, so I set the energy just energy is 2 joule, and the frequency is 20. Just the total energy is 40. Yeah. You see, is it?
What size fiber are you using?
272. 你来洗，因为这个光线有点短，我调了个这么短的光线给我，不要换了，这个马上结束。
So the new generation machine can provide more energy.
Yeah, more energy, high energy, yes.
And can make the operation faster.
Yes. So we always, yes. Just Professor Lee, we always talk about this just in the future, where flexible ureteroscope just replace PCN.
Yes.
If we have just good energy, maybe yes.
Yeah, maybe we can change the indication of the sense rays. We can do more larger stone with this technique. I think two problems. One is the laser can provide the more energy, higher energy, so we can fragment the stone quickly. And another problem is how to flush out the fragments quickly. That's two different problems. So maybe some innovation about the energy about the laser. And another is to how to the innovation we can increase the irrigation, and at the same time we can balance the pressure. The pressure monitor, I think in the future, in the soon future, maybe that is the standard, because depends on the intrarenal pressure. If the pressure is lower, so we can increase the irrigation to make this step flush out the short time. We can short the operation time of this step, flush out all the fragments quickly. Yes. When you are using fast, one of the advantages is that you can get small fragments to be extracted. Is it not dangerous to it needs probably more experience to do this navigation with the sheet and the ureteroscope. It can endure the mucosa and in the beginning of praxis of young urologists, I think it's not a good idea to do this. Didn't you agree? Yes, we should choose. I think we should match the sheath and the scope well. Just if we use 11 sheets, you can use 8.5 scope. But if you use 10 sheets, just 8.5 scope is not so good. You need to choose the 7.5 scope. Yeah. But
when you use the 7.5 scope, you choose the 12 sheets. Oh, I think it is also not so good. You will find just irrigation always not so enough.
Professor, when you do your initial urethrooscopy, before you start lasering, you said you're assessing the ureter. If you find the ureter is very tight, what do you do?
Oh, yeah. Yeah.
In China, there are so many products you can choose. You can choose the smaller accessories and the smaller ureter.
Oh, I find that
what's the smallest access sheet you use? The smallest one may be maybe 10 or 9. Professor Sean?
Yes. Yeah. For today's surgery, I prepare 10 sheets, and we also have 9 sheets. Yes. If we meet the ureter is very tight, we can choose the 9 sheets. And nowadays we also have 6.3 scope. So if we meet this situation, we can choose this sheets and the scope.
The 6.3 euros flex for your scope.
Yeah.
Use. Do you always use a sheet?
Always use the sheets?
Yes.
Yeah, every patient I don't like just already use the scope to complete the eyes. Yeah. I always use it. I don't like. I use sheets always, every patient.
Yes. I think with the shoes you can flush out all the fragments. And especially especially in this chip flexible sheets, it's easy to fragment the stone. If you don't use the sheets, if the patient have the severe nephrosis, if you want the fragments, the stone or the dust in the stone, it's hard because the stone always move. And at the same time, with the shoes, you can decrease the pressure of the intravenous pressure, decrease the pressure. So I think it's for me, it's the same with Professor Shao. Always
Dear friend, professors, I almost complete my